For the first question, when I first started my nursing career, which much of my knowledge base was empirical based, of theory, science, and black and white facts. It was hard for me to think outside the situation that was in front of me because I hadn't developed my personal, aesthetic, or ethical knowledge yet. I will never forget this patient because I think back on all the ways I could have used my therapeutic sense of self to better understand what this patient was going through. This patient had been very recently diagnosed with throat cancer. He had a newly inserted PEG tube, receiving chemo and radiation, and was coughing up a lot of blood. This patient was a grouchy guy and continuously refused lab draws to see how his hemoglobin was doing with all the blood he was coughing up. I remember talking to him about the risk of not getting these labs done should his blood levels drop too much. Instead of taking the time to better understand this patient, I spent 3 days arguing with him about why he should be getting his labs drawn without once asking him or considering if he even wanted to live and having a goals of care discussion with him. I had at that time couldn't see past the facts that if this patient got his labs checked and received the blood, he would feel better. Why wouldn't he want to fight and live, I thought. Why bother even being in the hospital if he would just refuse treatment? When I came in for my 4th shift in a row, I came back to find that he had coded and died that night. I was stunned and blamed myself for weeks for not having the ability to convince him to get his labs checked, believing this would have saved him. That situation forced me to reflect on how I could have better approached this situation with this patient. I talked with my nurse manager, and that's when she asked me, had I ever considered having a goals of care discussion with him? Did he even want to live? The 3 days I was there, neither provider nor nursing had asked the question to the patient what he wanted, just what we wanted for him based off science and facts. I now try to ask a different set of questions when I approach my patients who are refusing medical interventions. I have learned to put my own bias and beliefs aside to view the situation from the patient's perspective. Because our job as healthcare providers to do no harm, and ethically, we have an obligation to give our patients all the options. These options include interventions that are not only life-sustaining, but also may provide comfort to the patient. There's an art to being able to communicate and relate to your patients that can get them to open up to you to share how they're really feeling. And to do this, we must not only hear what they have to say, but hear what they're saying when it's not being said out loud. The second question, Chin and Kramer based Harper's empirical knowledge as a way of knowing that focuses on the assumption that what is known is accessible through the senses. It is based off theory, observations, problem solving, and logical reasoning. It can be obtained through textbooks, practical experience, training, lectures, journals, and online resources. It is the basis for which life-saving skills and reasoning comes from on a practical level in order to approach and address the patient's immediate needs. It helps to organize theories and develop evidence-based practice based off research and experiences in order to provide the best quality of care. However, it is limited by exceeding the importance of human experience. The therapeutic and holistic side of nursing is what makes a profession an art form. The ability to peer deeper into our patients' lives with empathy and compassion allows us to approach situations differently and offer ourselves as a therapeutic way that plain facts and procedures can't. It's how we prevent patients from suffering and better understand the deeper meaning to what we are doing, to one of why we are doing it.